Thank you for joining the AHRQ Safety Program for Telemedicine, Improving Antibiotic Use. Welcome to the first onboarding webinar. Johns Hopkins University and NORC at the University of Chicago are excited to be partnering with the Agency for Healthcare Research and Quality on this very important program. My name is Sarah Keller. I'm an Associate Professor of Infectious Diseases at the Johns Hopkins University School of Medicine, where I see patients in the hospital, in the clinic, and over telemedicine. I am one of the leaders of this antibiotic stewardship project, alongside my colleagues at NORC at the University of Chicago and Johns Hopkins University. Should you have additional questions after this webinar, please note the safety program's email address is safetyprogramfortelemedicine@norc.org. We wanted to welcome all of you to this webinar. Some of you might be coming from practices where you see some patients in person and others virtually, and some of you might be coming from practices where you see all patients virtually. None of the presenters have any conflicts of interest relevant to this program. The faculty and the planners or managers for the Postgraduate Institute for Medicine, Johns Hopkins University, AHRQ, and NORC also have nothing to disclose. In support of improving patient care, this activity has been planned and implemented by the Postgraduate Institute for Medicine and NORC at the University of Chicago. Postgraduate Institute for Medicine is jointly accredited by the Accreditation Council for Continuing Medical Education, or ACCME, the Accreditation Council for Pharmacy Education, ACPE, and the American Nurses Credentialing Center, ANCC, to provide continuing education for the healthcare team. For physician continuing medical education, this live activity is designated for one AMA PRA Category 1 credit. This activity is designated for one AAPA Category 1 CME credits. For continuing nursing education, the maximum number of hours awarded is 1 contact hours. This activity is designated for 1 IPCE credit. Successful completion of the CME activity, which includes participation in the evaluation component, enables the participant to earn up to 1 medical knowledge MOC points and up to 1 practice assessment NOC points in the American Board of Internal Medicine's ABIM Maintenance of Certification MOC program. This presentation will provide an overview of the AHRQ safety program for telemedicine, improving antibiotic use. By the end of this module, participants should be able to describe the purpose and goals of the safety program, summarize the timeline and expectations of the program, including how to submit data, and describe how to interact with the website and how to reach out to the safety program team. Welcome again to the AHRQ Safety Program for Telemedicine, Improving Antibiotic Use. We developed this program because of a need to reduce inappropriate antibiotic prescribing during the era of telemedicine. Telemedicine use exploded during the COVID-19 pandemic. In the US, antibiotic-resistant organisms cause 2 million infections per year and 35,000 deaths per year. Side effects from antibiotics prescribed in ambulatory care lead to 150,000 emergency department visits per year. Judicious use of antibiotics is especially important in the telemedicine environment, as infection-related complaints make up a large portion of telemedicine visits, and 2/3 of visits for upper respiratory infections inappropriately result in an antibiotic prescription. Unnecessary and overly broad antibiotic use directly contribute to antibiotic resistance and make future infections more difficult to treat. It is important to improve patient safety by reducing harm due to unnecessary or inappropriate antibiotic use. For this reason, antibiotic stewardship in telemedicine is essential, but improving appropriate antibiotic use requires addressing multiple barriers. This program will address many of these barriers, including time pressure, inability to perform a physical exam, and lack of access to diagnostic testing. The program will also address issues surrounding patient satisfaction and communication, as sometimes there is a perceived patient desire for antibiotics, and as patients may not understand the potential negative consequences of antibiotics. The main goal of this program is to improve antibiotic decision-making and patient safety in primary and urgent care settings that provide care via telemedicine only or a mix of telemedicine and in-person care. Additional goals of the safety program are to reduce prescriptions of unnecessary antibiotics and patient harm while maintaining patient satisfaction. We will help practices implement evidence-based strategies to improve the diagnosis and treatment of infectious conditions over telemedicine. The safety program also aims to strengthen the culture of safety and improve communication and teamwork around antibiotic decision-making in telemedicine. Along the way, there are many benefits to participating in this program. You will learn evidence-based strategies for the diagnosis and treatment of infectious conditions in telemedicine settings. You will also improve patient satisfaction and communication in patient visits and interactions focused on infectious conditions and appropriate antibiotic use. Additional anticipated outcomes of participation include enhancing patient safety and reducing harm from side effects and adverse reactions to antibiotics. Additionally, this program may aid the patient-provider relationship by improving communication about appropriate antibiotics while streamlining clinic visits. This will include scripting for both patient portal messages and live interactions with patients to decrease provider burden. AHRQ previously funded the development of antibiotic stewardship toolkits for the acute care, long-term care, and ambulatory care settings. The toolkits were each delivered over 1 year in a safety program format. 402 acute care hospital units, 439 long-term care facilities, and 389 ambulatory clinics participated. These 3 previous safety programs led to statistically significant reductions in antibiotic use and improvements in appropriate antibiotic use. In the program focused on antibiotic stewardship and ambulatory practices, participating practices saw a 9% decrease in antibiotic prescribing overall and a 15% decrease for acute respiratory infections, or RTIs. Pediatric practices saw an 11% decrease in antibiotic prescribing overall and a 13% decrease for RTIs. We hope to see similar improvements during this program. Your fellow participants will include primary care practices, including internal medicine, family, and pediatrics, outpatient specialty practices that provide primary care, such as gynecology, community-based health clinics, student health clinics, retail clinics, occupational health, urgent care clinics, virtual first practices, and direct-to-consumer practices. Practices in this program can see patients exclusively via telemedicine or via a mix of in-person and telemedicine visits, and can be in any location, including rural, suburban, or urban settings. The AHRQ Safety Program for Telemedicine, Improving Antibiotic Use, is an 18-month program that runs from June 2024 through the end of November 2025. As a reminder, this program is offered at no cost for enrolled practices and does not require a contract or IRB review. And as another reminder, continuing medical education credits, CMEs, and continuing education credits, CEUs, are available for participating physician and nursing personnel. To earn these credits, participants must attend live webinars or review recorded project webinars, or the slides and script for the webinars asynchronously. Maintenance of certification points, or MOCs, will also be available. Each month, we will focus on a different topic related to developing and implementing antibiotic stewardship in telemedicine, communicating with patients, caregivers, and colleagues over telemedicine, and best practices for diagnosing and managing common infectious syndromes and antibiotic allergies over telemedicine. These topics will be presented with live educational webinars, recorded webinars, and slides with facilitator guides for review. Supporting information will include clinician handouts, including discussion guides, as well as patient portal messages and patient and family education and communication materials. Program materials are designed to be easy to implement and improve efficiencies in your practice. Every month, participants should review one of these educational materials, either the live webinar, recorded webinar, slide set with facilitator guide, or clinician handouts with discussion guides. In addition, participants can join office hours with subject matter experts. Leaders at each practice will also assist with data collection and submission activities, and meeting with a dedicated implementation advisor, a quality improvement expert, who will provide expert coaching throughout the program. Your implementation advisor, or IA, will provide individualized technical assistance or implementation support. Your IA will be your main point of contact for any questions about the program, including help with website access and assistance with data submission or data quality issues. You will have monthly check-ins with the IAs. If you have not already received a welcome call from your IA, please know that they are in the process of reaching out and you should hear from them shortly. In addition, every month, after reviewing the educational material, practices should meet to discuss that month's topic and practice-wide approaches to implement antibiotic stewardship. The clinician lead can guide these meetings. For some virtual first or telemedicine-only practices, several clinicians may need to gather with practice leadership or organize regular meetings with other clinicians to discuss approaches to implement antibiotic stewardship. Discussion guides can help direct these conversations. The discussion guides will also include synchronous and asynchronous scripts and triage protocols for patients presenting with symptoms of common infectious syndromes. In your regular practice meetings, think about how you can incorporate these triage protocols and asynchronous or synchronous scripts into your practice. These scripts and protocols have been designed to increase practice efficiency while improving patient satisfaction. Every member of the practice is an important part of this program. However, 3 individual practice members have special roles in the safety program. The clinician lead can be a physician, nurse practitioner, pharmacist, or physician assistant. In a brick-and-mortar practice with multiple clinicians, this clinician is seen as a leader in the practice and works to lead the telemedicine practice in implementing antibiotic stewardship. In a virtual-first practice, this clinician lead is the individual clinician participating in the safety program. The administrative lead is an individual who could be a clinician or a member of the office staff, or even someone working in practice leadership who can help organize members of the practice to come together for practice meetings to discuss antibiotic stewardship, and who can learn how to pull and upload visit data and antibiotic prescribing data to the project team. The executive sponsor is a leader in the organization who can help provide the resources necessary to implement antibiotic stewardship. Examples include, but are not limited to, accessing antibiotic data, making changes to an electronic order entry system, and other examples. We will cover topics in educational webinars, such as how you can implement antibiotic stewardship in telemedicine and diagnosing and treating common infections over telemedicine. On the screen are topics we will be discussing. The safety program's educational material focuses on 3 main ideas. First, it focuses on developing and improving antibiotic stewardship activities in your telemedicine practice. Second, you will learn strategies for communicating over telemedicine with patients, families, and colleagues about antibiotic prescribing. Third, you will learn best practices for diagnosing and managing common infectious syndromes and antibiotic allergies over telemedicine. All members of the practice are welcome to view all components of the safety program. The antibiotic stewardship leads, that is, the clinician lead and the administrative lead, should carefully review material related to developing and implementing antibiotic stewardship in your practice. The clinician lead and the administrative lead should take this information and present the information to other members of the practice in a regularly scheduled practice meeting or in other meetings scheduled specifically for antibiotic stewardship activities. All members of the practice, including the antibiotic stewardship leads, clinicians, and practice staff, are part of the safety program. Everyone who may interact with patients and families should view information about communicating with patients, caregivers, and colleagues. Learning how to communicate with patients and families about appropriate antibiotic prescribing is key for all members of a practice. In addition, it is important that a practice take a common approach to antibiotic prescribing, so it's important that all members of the practice review materials related to teamwork and communication among members of the practice. Finally, clinicians should review the information on best practices for diagnosing and managing common infectious syndromes and antibiotic allergies over telemedicine. During the project, we'll ask you to collect data to help understand the safety program's impact on practice culture and structure. First, practice will complete surveys at the beginning of the program, including a structural assessment for all practices and the AHRQ Medical Office Survey on Patient Safety Culture, or MOSOPS, for brick-and-mortar practices only. These surveys will be repeated at the end of the program. At the end of the program, there will be a patient experience survey. There are also optional interviews at the end of the program. We also ask that every quarter, practices submit visit-level data for acute respiratory tract infection-related telemedicine visits, including any prescribed antibiotics, from the electronic health record, or EHR. The program staff will be available to assist in understanding how to collect data from the EHR. The EHR data will be used to measure the total number of antibiotic prescriptions per 100 respiratory tract infection, RTI-related telemedicine visits, and the total number of antibiotic prescriptions per 100 antibiotic inappropriate respiratory tract infection, RTI-related telemedicine visits. Let's go over the timeline for data collection for the program. Surveys and EHR data collected at the beginning of the program will be collectively referred to as baseline data, since they are the first data collection points for the program. Surveys collected at the beginning of the program should be submitted by August 31st, 2024. You will then submit EHR data on September 14th, 2024, and this will include data from March 2024 through August 2024. Throughout the program, you will submit monthly AHR data at the end of each quarter. For example, by December 14th, 2024, you will submit AHR data from September 2024, October 2024, and November 2024. Surveys collected at the end of the program will be collectively referred to as end-line data, since they are the final data collection points for the program. End-line surveys will be submitted November 30th, 2025. The first quarter of AHR data will be submitted December 14th, 2025, and this will include data collected through November 2025. There may be some challenges to getting these data together at first, but you will be able to work with your implementation advisors to get advice and help you out. After you do it a few times, it should get a lot easier. Okay, let's go over at a high level what you are and are not pulling together from your electronic health record as part of this program. What is being collected? For each acute respiratory tract infection related telemedicine visit, you'll be asked to provide the following information. First, enter a unique provider code. Your practice will be asked to create a unique code for each participating provider. This will allow the program to capture the number of providers contributing to the prescribing rate while maintaining the anonymity of participating providers. Second, enter ICD-10 codes for any primary or secondary diagnoses. The data template includes a list of relevant RTI ICD-10 codes to be included, as well as ICD-10 codes for conditions that might exclude a telemedicine visit from the data. Third, enter CPT codes to confirm the visit was via telemedicine. Look at the data template to identify relevant telemedicine CPT codes. Fourth, enter the name or national drug code of any oral antibiotics prescribed for that visit. For antibiotics, we are collecting data each month about oral antibiotics that are commonly prescribed in telemedicine practice. The data template includes a list of national drug codes that correspond to these oral antibiotics. We are looking for the name of each antibiotic prescribed, nothing about frequency, amount, or duration. So, as an example, a prescription for amoxicillin 500 milligrams 3 times a day for 10 days would be captured as amoxicillin. Each oral antibiotic listed should be associated with a respiratory tract infection-related telemedicine visit. There's a reason why we focus on data collection in this program. Tracking and reporting data is a key antibiotic stewardship intervention. The CDC core elements for telemedicine antibiotic stewardship even lists tracking and reporting antibiotic data as a core element for antibiotic stewardship. Unless you know how well your practice is following antibiotic prescribing guidelines, it is hard to make a positive change in antibiotic use. So, knowing how to collect and look at your data can help you meet your antibiotic stewardship goals. We will provide feedback on the data we get from you after running quality checks on the data. Your implementation advisor will be in touch about those questions or problems about the data. In addition, we will provide a quarterly benchmarking report that will compare your practice to the program. Reports may also need to be tailored to meet your practice or organization's needs. So, thinking beyond the data you are going to submit to the program, how can you use your data? Is your practice going to be looking at data from individual prescribers or groups of prescribers? Also, what sorts of data are you going to focus on? You could focus on overall antibiotic prescribing. You could also focus on diagnosis-specific antibiotic prescribing, like antibiotic prescribing for non-specific upper respiratory tract infections or acute bronchitis. In addition, you could look at information about use of specific antibiotic classes that might be of specific interest, like fluoroquinolones. Of course, just getting the data is not enough. If we want all the work you are doing to pull these data together to effect change, the data need to be seen by the right people, discussed, and actions taken. It is key to think about to whom the feedback is going. If your practice has more than one prescriber, is the feedback going to individual prescribers or the whole practice? For clinic-based practices and telemedicine-only practices, is the feedback going to practice or health system leadership? You also need someone who can disseminate the reports to the right person, group of people, or the whole practice. This messenger should be a person in your organization who is recognized and respected, particularly in providing or fostering high-quality care. This person can be the clinician lead of the stewardship program or part of the practice clinician leadership. The messenger is not only going to send out reports, but might need to provide additional education about the measures or about the clinical topic. The messenger also needs to be ready for disappointed or upset colleagues. The messenger will hear things like, "Your data are wrong. You don't know what it is like to provide frontline care. My patients are sicker," or "My patients really demand antibiotics." So the messenger should be in a position to address these concerns. Talk with your practice and your organizational leadership about how you want to use your data. We will give examples throughout the safety program. After this call ends, your next steps are to meet with your implementation advisor. Log onto the program website. Work with your antibiotic stewardship team, your clinician lead and administrative lead to set up practice meetings to discuss antibiotic stewardship. We also ask you to start working on the baseline surveys. Then work with your implementation advisor to prepare to extract relevant EHR data for all RTI-related telemedicine visits. Make sure you can log into the website safetyprogram4telemedicine.org. The main contacts at each practice should have received login credentials for the safety program website via email. If you haven't, please contact your implementation advisor or the safety program at safetyprogram4telemedicine@norc.org. There you can review the webinar schedule, watch recordings, download slides, and other program materials such as patient education resources, patient portal messages, and verbal scripts, and submit data. Additional practice members can also be registered to go onto the website. Ask your implementation advisor to register additional users. This program addresses a common problem by providing an opportunity to improve the diagnosis and treatment of infectious conditions in telemedicine. We will provide you access to tools that will assist and support you and your teams in your implementation efforts. If your practice encounters unforeseen challenges, we will work with you to meet your needs. We look forward to working with you to improve antibiotic use. Thank you. We'll be happy to answer questions at this time.